Hi everyone, my name is Fatima Mansour and I'm part of the team working on the Clarity trial. Now Clarity is a study looking at how we can improve patient outcomes for the commonest general surgical emergency, appendicitis. I'm going to start by giving you a short introductory presentation on the Clarity trial, followed by a discussion with my colleagues on some of the challenges and insights that we've gained along the way. Now the reason we think this is a really crucial problem to address is that we've carried out some of the largest national and international studies looking into right iliac fossa pain management. And what we've found is that there's significant variations in practice in the UK, and that our patients had very poor outcomes, particularly when you compare us to other European neighbours. In front of you is a simplified schematic of the right iliac fossa pain pathway. And what you'll see is that of those who are admitted under the general surgery teams for suspected appendicitis, in the UK, only about a third of them have the correct diagnosis and management. The overwhelming majority actually don't have appendicitis, but are admitted and don't receive further management. We've called these non-operative admissions. At the bottom, you will also see that some of the patients who don't have appendicitis are admitted and actually do go on to have negative surgery. This has also been associated with a high wound infection rate and other post-operative complications. So effectively, admissions almost seem to form a nodal point of entry where patients can be either unnecessarily admitted or receive unnecessary surgery. So we started to ask, could we develop something like an educational intervention targeting surgical teams and see if this would actually change their long-standing practices and improve patient outcomes for suspected appendicitis? With regards to the methodology, we are running a multi-centre cluster randomised trial with a parallel design and a one-to-one allocation. This means that 50% of the sites are randomised to intervention and the other half are serving as controls. The aspect that's a little bit different in this trial is that our participants are actually the surgical team members. This not only includes doctors who are involved in the diagnosis and management of appendicitis, but also other allied health professionals such as SNPs and physician associates that are involved in this process. Our target population is a slightly younger one, as we believe that these are the ones who tend to have a poorer outcome. So this included all patients coming in with suspected appendicitis aged 16 to 39. As I explained, our primary intervention is an educational one, and it's targeted to surgical teams. Other aspects alongside this includes a checklist as well as local team building strategies. In terms of our outcomes, the primary outcome is to try and reduce the overwhelming problem, which is non-operative admissions, but the secondary outcomes also look into how to improve patient safety, such as reducing the normal appendicectomy rate, as well as other safety parameters. A quick word on our intervention. Our education programme was specifically designed for surgical teams, and we were able to target different versions according to the expertise of the staff member. Furthermore, the content of the module contained the highest quality evidence for diagnosing appendicitis, but it also included practical steps or an algorithm for implementing this evidence into daily practice. And alongside this, we also included a memory prompt checklist and also worked with sites to engage them in team building and facilitating implementation as much as possible within this environment. So Clarity will be the first study to address this problem within the UK. And although there is many potential benefits to our emergency SAU services and benefits to participating in collaborative research, our main motive is to improve patient outcomes and to try and reduce unnecessary admissions and surgeries for right iliac fossa pain. Now I'm going to move on to a discussion with my colleagues about what we ended up doing within Clarity.
Well, Fatima, that was a fantastic talk. Thank you for the introduction to the study. Amanda, would you like to introduce yourself?
Yes, thank you, Prof. My name is Amanda Godoy. I'm one of the foundation doctors in North England, and I am one of the STARSurg committee members as well, participating in the trial.
And it's been a great pleasure to work with you over the last year, both of you and the whole team. It's certainly been a challenging year, but it's also been a very exciting year. So, Amanda, how do you think medical students and FY1s have contributed to the success of the trial?
Yeah, thank you. That's a great question, Prof. I believe that in busy emergency settings where the staff are often stretched, to say the least, the students, the foundation doctors, they bring time, they bring energy, and they bring genuine enthusiasm for the research that they're in the start of their careers. And that enthusiasm, it often translates into the reliability, collecting data, and importantly in motivation for the wider team. In many sites during the trial, we saw that students and the early career doctors, they not only collected data, but they also prompted the principal investigators, the PIs and APIs to stay engaged. They arranged meetings and they drove momentum in the sites. And in that sense, they weren't simply assisting data collection. They became an essential part of the multidisciplinary team.
I think there's too much modesty in what you're saying, Amanda. I've been absolutely knocked out by the organizational capabilities of STARSurg. It's been incredible, and the leadership team must be commended. I'd like to stay with you for a moment, Amanda. So obviously there have been great highs, but we've also had lessons to learn, haven't we? What lessons have you learned from running Clarity?
That's a full question. I think communication between us, coordinators, the central team, and the people on site, we had to adapt quite a lot. So we adapted some innovative strategies for communication using more technological and more sort of recent apps, let's say WhatsApp, to communicate with the sites other than just email. And we also tried to, even before randomization, get in touch with the sites, understand the behavior, how the discharge pathway was for each of the sites, how the ambulatory care was like in each of the sites as well, so that we could have a better understanding once they either started the intervention or remained in control, how we could best help them. So I think communication and knowing what is of value or what sites are struggling was essential for us to understand the difficulties of running a trial in a real world setting where so many professionals are involved.
Yes, Amanda, I'd have to agree. I think there's a kind of overview that the management structure kind of evolved during the trial, and we learned a lot about how to do it better. Perhaps back to you, Fatima. Alongside the kind of delivery of the trial, there was the methodology of the trial. That was quite a challenge. Were there any particular issues around the methodology and its delivery that we had to address, do you feel?
Absolutely. So, Dion, it's needless to say, right iliac fossa pain management in the UK is a bit of a long-standing odyssey of patients receiving unnecessary investigations and then going on to have unnecessary surgery. So to really break away from practice like that is difficult. One thing we sort of emphasised quite a bit in Clarity was an educational package which is specifically tailored for the surgical team. So we, over time, realised that we needed to tailor this according to people's seniority, what their interests might be. But actually, at the end of the module, every single team member, whether you are quite junior or an allied health professional, was on an equal footing in terms of understanding the latest evidence the latest evidence base for assessing and managing appendicitis. And what that allowed was this sense of cohesion and alignment between the teams so that everyone knew what the next steps were. And that was really important, I would say, in terms of getting our intervention right. I'm not sure if you would agree that actually this kind of model might be a really interesting model for looking at pathway-related outcomes in the future. Would you say so, Dion?
Oh, absolutely. I think that the ability to change practice and improve patient outcomes over months instead of years, and to reach out across hundreds and hundreds or even thousands of clinical staff in one go. I think the methodology is fantastic, and I think it has wide applications for surgical patients. But you've both emphasized that actually it also needs persistence and a very good management structure to deliver what's required and to sustain the pressure to keep the momentum up. So I'd like to just congratulate you both and the whole management team for what they've delivered. The patient follow-up will be finished at the end of October. The data cleaning will take place before December, and we'll be looking for the main paper to come out in Q1 2026. Thank you.